It's a great honor and a pleasure to present today. And as you've heard now, I'm here with my co-author Julia, and our presentation is about a paper that we published in BMG Mental Health in 2023, titled Depression, Violence, and Socioeconomic Outcomes Among Refugees in East Africa, Evidence from a Multi-Country Representative Survey. One of the pictures you see here in the background is actually Doloado refugee camps, so a refugee camp in Ethiopia, where some of the data collection happened, just to give you a little bit of an idea what the environment and the context is that some of the data is coming from. So this research project is actually a collaborative project with Dr. Olivier Sturck from the University of Antwerp and also the University of Oxford, and Maria Flinders-Stierna from Norwegian University of Life Sciences. Unfortunately, they can't be here today, but they obviously equally contributed to the paper. So the study in many ways connects our expertise in different fields, from development economics to mental health and refugee studies in general. And in a way, the project started many years ago when Olivier, Maria, and I were working together at the Refugee Studies Center, the Refugee Economies Program, and basically doing data collection in different contexts in different Eastern African countries, and we'll talk about that later. But basically something that we observed was how much mental health issues play a role in that context, and that came up over and over again. And we saw that in our data that we were collecting. And so we reached out to Julia, a dear friend of mine, who was then doing a PhD in psychiatry at the Department of Psychiatry here in the University of Oxford. And so we worked together on this project. And this is how basically this interdisciplinary approach came together. And in a way, I would like to maybe hand over to Julia and to start us off with a little bit the rationale behind this survey.
Thanks very much, Raf, and thanks everyone for joining. It's exciting to have such a big group to present our findings, which we were very excited to publish a few years ago. So as Hannah was saying, so part of my work is focused on developing scalable treatments for depression in low income settings. And another big area of my work is on what I call diagnosis, which is on relying on very large surveys to understand depression and other common mental health disorders around the world, but specifically in places where there is very little data to understand how many people are depressed, access to treatment, and access to effective treatment. So part of this area of research was this work fits into this area of research, and alongside this, I'm also working with colleagues at Harvard on the World Mental Health Survey, which is one of the largest studies on mental health, trying to analyze access to treatment among different subgroups and countries. And so the idea with this project and this presentation is to really give an overview of the data that we have, which is, as you will see, it's a big, large, nationally representative survey trying to understand the mental health, depression specifically of refugees in East Africa. And this is just a first step among what would come from other projects focusing on more, now that we know how many people are depressed, what is there to do. So before we go into the rationale of why focus on refugees in East Africa, I want to read a quote from Tedros, who's the WHO Director General, really basically describing the impact of mental health on refugees. It's a hidden epidemic and a silent killer. News reports shows us the devastation of war. They shows us refugees on the move, refugees in cities and refugees in large camps. But they don't show us inside the minds of the people and how it affects their lives. Wounds heal, homes are rebuilt, news cycles move on, but the social scars often go unnoticed and untreated for years. And so that's the problems that we're focusing on in this project. The main problem is that there's more than 117 million people that have been forcibly displaced by 2023. And most of them are hosted in low and middle income countries. And they, during their exile and during their experience, they accumulate a lot of trauma and stressful moments, which basically put them at a very increased risk of developing mental health disorders. And these mental health disorders tend to persist the longer the exile. So this graph on the right shows refugees by population around the world by 2023, so cumulatively, where it shows that there's also a big portion of refugees in the whole of African continent. And the main reason why we think it's the added value of this study really is that even though most of the refugees are hosted in low and middle income countries, most of the studies on refugees are actually focused on refugees that have settled in high income countries. And so that's where we think this type of data that the Refugee Center here at Oxford is collecting is really a goldmine. And it is also the case that most of the research focused on mental health of refugees is done with very, very small samples, often non-representative, and have very low response rates. So they are limited in how generalizable they are to other contexts. And just in general, I think parting from what Raf was saying around the interdisciplinarity of this group is that we focus not only on the clinical impact of depression on individuals, but also the knock-on effects that depression might have on other outcomes. So things like how much you invest in the labor market outcomes, things on more generally well-being or health outcomes like diets. So that's why we think the gaps are in the literature, and what brings us to this study. And so this study tries to address some of these gaps by conducting a multi-country survey of refugees and also host populations living in the similar context. And the aim of the study was to present representative findings on the prevalence of depression and the correlates with other outcomes such as exposure to violence and socioeconomic outcomes. And all of this is done in refugees living in East Africa. Great. So just specifically on the objectives that the study had is that, as I mentioned, so the first one is to really focus on the prevalence of depression. So how many people are depressed, something that we really lack. There's limited data on currently. And then what are the correlates? Are there specific groups that are more likely to be depressed than others? How does that compare in terms of the refugees versus the host populations that are living in nearby or similar context? Once we know what the prevalence or the diagnosis of it all, then we go and say, okay, we focus on one of the major risk factors for depression, which we know, which is the exposure to violence. And it's exposure to violence before exile. And so Raphael will be describing two different measures that we relied on to try to understand how did exposure to violence before exile could have been correlated with higher depression prevalence at the time once they were settled in different camps or settings. That's objective number 2. And then taking all of this together, what we're trying to understand is, given the prevalence of depression and the very high exposure to violence that we find in the study, can we look at other knock-on effects of depression in other important outcomes, like, for example, employment status, income, dietary diversity. And so we will be looking at different measures that Raphael will be describing. And so that's the study objectives come together in as a whole like that. Okay, then I'll hand it over to Raph, who will be talking a little bit more about who they surveyed and who the people are.
Thank you so much, Julia. So, as I mentioned before, this project started with the Refugee Economies Program. And the Refugee Economies Program, our initial goal was to look very much at the socioeconomic outcomes and the economic life of refugees. And mainly in so-called protracted refugee situations. So these are situations in which refugees live for many years, often more than 10 years. And that's why basically we focused on, or have this regional focus on Eastern Africa. That doesn't mean that similar contexts do not also exist in other contexts, right? So that there's not another, we could also have done something similar in a different context, but this is where the project started in 2016, when the first data collection started. And then the data collection basically continued until end of 2018. So we collected the data across 3 different countries, Kenya, Uganda, and Ethiopia. And we focused on both urban areas and refugee camps, or like refugee settlements, as we call them in the context of Uganda. And in Kenya, we've done the research, or like the data collection in Nairobi, focusing on Somali refugees and Congolese refugees. These are the main populations in Nairobi. And in Kakuma refugee camp, a big refugee camp in Kenya, we focused on South Sudanese, Somalis, and Congolese refugees. There are obviously many other refugees that come from different contexts, for example, from Ethiopia, even from Burundi, for example, etc. So there are different refugee populations, but they are much smaller in these particular different refugee contexts. And so we focused on the main populations. In Uganda, our research focused on Kampala and Nakivale, and there on Congolese and Somali refugees. In Ethiopia, we had Addis Ababa, the capital, and 5 refugee camps around Dolo-Ado. And there it's mainly Somali refugees. In Addis Ababa, we also interviewed Eritrean refugees, but they were not part of this particular mental health study because of data connectivity issues. We couldn't link them properly with like exposure to violence, but that's something we can discuss later. What all of these refugees have in common, despite coming from different countries, arriving at different times, living in very different contexts, they face overlapping vulnerabilities. So that includes protracted exile. This includes like limited access to services, and as we will hear, also exposure to violence. And our idea was that by working across these different contexts, that we can really paint a comprehensive picture of a population as a whole, and basically generalize a little bit more than just talking about very specific small focus group discussion in like one particular context. So overall, we talked to almost 16,000 people, and so that's 8,300 refugees and like 7,600 host population members. So that primary data collection was done in an approach that in a way we're a little bit proud of, and that's a very inclusive way of doing data collection, because we worked basically exclusively with community members, meaning we've trained refugees in these different refugee communities to do the data collection. And we trained host community members to do the data collection in the host community. When I'm saying host community, then that means basically nationals, like citizens of these countries where the refugees are hosted in. And I talk about people that are living in the proximity, for example, villages around the camp, or the neighborhood in the city that is surrounding that area in a city where refugees live. That specific group always looks a little bit different depending on where the data was collected, but overall that's the idea. We did our data collection in a mixed method approach. And what that means is that, of course, we have a representative household survey, but we also did over 600 qualitative interviews over the course of these 3 years in these different contexts. That is data that we will not present here, but it has definitely influenced our data collection, our interpretation of the results, and more or less the way we basically do research in these different contexts. We have employed basically simple randomization or 2-stage cluster techniques, depending on the context. That has something to do with the availability of sampling frames or like census data, depending on the context. And I'm happy to talk a little bit more about the details maybe later, and yeah, maybe go on for now. But I'm happy to talk about the different contexts in terms of data collection. To provide you a little bit on an insight into, maybe let's go back for once, and let me quickly say something about the picture you're seeing. That image is one of our enumerators, a South Sudanese refugee. He's working with us in Kakuma refugee camp and doing a household survey in Kakuma refugee camp. And let me tell you a little bit something about the context, at least some part of the context, because I'm not sure how familiar you are with the different refugee contexts. Besides, and Hannah has said something about this already, like I'm also a filmmaker, and we have another project, or I'm running another project that is called the Refugee Stories Project, where we're working together with refugee filmmakers to tell the life stories of refugees. And in the context of Kakuma refugee camp in Kenya, we are currently in the process of creating or making short documentaries about the life of refugees. And I would like to use this opportunity to show you two 1-minute videos where refugees talk about aspects of their life. And I think that highlights aspects. So these videos are not made for the context of a mental health research. But I think having the mental health question that we're talking about today in mind will show you something about what's going on in these contexts. And so the first video is Abdirazak. He's a Somali refugee living in Kakuma camp in Kenya. He's 55 years old. He lives alone, and he came to Kakuma more than 10 years ago, fleeing conflict in Somalia. And the video that you will see now is made by one of the refugee filmmakers we've been working with.
Let me just confirm, do you hear the audio?
Yes,
No?
I think
Yeah.
it will pick up.
islaantaydu waa la dilay wiilkaygu waa la dilay gabadhaydu waa la dilay oo anagoo inta jooga la ii sheegay Kakuma dhibaato badan kula soo kulmay baagamoonda askari ana saan barahay ku kutubay aan gaarigay wada isku kutubay dadka aska baryan jiray waxaan dhihi jiray war kaar isiya war telefoonka aan gashado warkii soo socdaa leedahay naga taga leedahay 2016 kii furay horto inta aan furin dukaanka gaarigaas uu ahaa saanu shaqeynay marba shanta konton shilin meel dhig 20 meel dhig konton meel dhig saan u lahaa hooyar markay aan ii aruureen iyo meeshan ku dhisay waxaan gadaa wax dadka aad u nacaba gadaa horta waxay yihiin sigaaran gadaa ana maan cabo waana gadaa nafta ii geysay in aan gado dhibaatada Kakuma taalo ii geysay lacagaha u badan meeshan horta lacag ma taalo aqli basar sir siyaasad isku wada ma ogi oo meel oo lacag taalo oo wax laga soo qaadayo ismu jeedaan.
Let me maybe immediately jump to the next video, which introduces Rose. She also lives in Kakuma, or like a sub-part of Kakuma, which is called Kalobei. She's in her early 30s. She's also, she's from South Sudan, and she lives together with her 4 children, while her husband remained in South Sudan. And maybe one thing to add to her video is that, similar to her, 90% of all households in Kakuma refugee camp are currently struggling with debt. Maybe that's a number to keep in mind.
Jamani na gomde moria taija sulpa. Jamani wa ina wata gero akap ya okele mgana gero belit kile tebi bagar bara chanta berwa pe kamel bayal. ina kulu 5 في بيت شغل تاني ما في على أنا قشكل عشان أنا بيشادو أشهر تاي بس أنا قاكل بامبا بامبا سبا جيبوا قروش يا أنا كان قروش نجيل أنا غيروا أنا قيل يقول سيدي دكان أنا جيبوا أكل قروش تاي بيجا 9,000 ما في اللي أنا رجع في البيت عشان أنا غيروا قدام بدين جكان بدري في بيت aja kulu ana babiu bebiu kata ile ana shibu le shiri dokan akel kanana jebo pibet magi shilo jaman ana gibiu kashap magi timo shar yana gala go shar tane guam.
Great. Thank you very much,
Jaman na
Raf, for those really great videos. And I'm sorry the audio was low. We just couldn't manage to get it. I don't have the best computer. So before going on to the results, we're going to discuss the methodology. So the measures we use to assess mental health, and then the exposure to violence and socioeconomic outcomes we focus on. So we look at 2 dimensions of depression. The first is the depressive symptoms, and to measure that, we use the patient health questionnaire, the 9 items, which has been used before among refugees in Somalia, South Sudan, and DRC, with good psychometric properties. And we focus on 2 different measures. The first one is the total score, which goes from 0 to 27. With higher score, the higher the depressive symptoms. And then we use the standard cutoff of 10 to indicate moderate to severe depression. So it's a binary variable to indicate those that are in that depression range. The second measure we use is functional impairment, so to see whether not only having depressive symptoms, but it also how much it affects their daily functioning. And for that, we use the HUDAS, the WHO Disability Assessment Schedule, 6 items of those, and it assesses functioning in 4 different domains of life: mobility, life activities, cognition, and participation in community life.
One of our goals was to measure violence exposure and in the country of origin, so before exile. And so what we knew from our household survey is where people are from and when the people have left the country of origin. And so we worked on connecting that data with conflict event data. So conflict event data, we used the so-called ACLED data, so that's armed conflict, location and event data. And they record incidents of political violence and protest. And that is usually reported by local, regional, international news organizations, international organizations or NGOs. And we then, based on that conflict event data, we connected that with the information about where people and when came from and when they have left. We decided to look on the second level of administrative unit. So in the case of Somalia, for example, districts or so-called counties in South Sudan. And then we mapped on, we counted basically the number of conflict events per 1,000 people, created an index per 1,000 people living in that county or district, and measured that over the 3 years before leaving that context. And that index that's how we built an index or score for that so-called objective exposure of violence. I'm happy to answer a couple of questions about that. There are definitely challenges that come with this. And there is a reporting bias in that sense that there's only events recorded that are reported and then picked up by the news, obviously. There's a bias in that sense that we're only talking about political violence. We're not talking about crime. We're not talking about domestic violence. And there's a problem in that sense that flight routes are messy. So only because we know when somebody has left their country of origin and we know that where they come from, doesn't mean that they might have not been exposed to other conflict events on their way. And so while that data is objective in that sense that it happened before the exile, that exposure, it is obviously like not without its challenges. Therefore, we asked people directly about their exposure to violence. And we asked 3 questions. We asked if they've been victims of violence in the past, if they've been victims of torture, or if they have witnessed violence or torture. The problem here is, of course, that is a very subjective question in that sense that it matters what people understand as violence. It matters also in that sense that we think that if you've been traumatized, certain things might be more on your mind than if not, right? So it's a very subjective question. Maybe we can just like go on.
Yeah.
In terms of the socioeconomic outcomes, we looked at 4 different dimensions. So we measured the employment status. It's just a binary variable of identifying respondent if they have an income generating activity. We obviously then, if they have an income generating activity, asked about the income they generate. We also asked about the life satisfaction. So that's a rated scale from 1 to 5. How satisfied are you with your life currently? And then we also asked about dietary diversity. In dietary diversity, we employed food intake measurement, the individual dietary diversity score. It's used in this context like very often. And the idea here is to look at socioeconomic factors that describe and measure people's lives even without having necessarily like formal employment status or income. So even without that, we have some variety. Maybe you could.
Yeah, well, in terms of analysis, just briefly. So as I mentioned, so we first look at prevalence. So we do just some simple t-tests to compare prevalence of depression and functional impairment among refugees, different groups of refugees, but also compared to the host population. And then we look at regression analysis, so using OLS to look at basically the exposure of violence pre-exile with either prevalence of depression or the relationship with socioeconomic outcomes. So it's a simple analysis. So we can walk on through the results. Just as a start off, this graph is showing you the prevalence of depression. And again, this is just showing you the binary variables, so those that are above the cutoff of 10, so in the moderate to moderately severe range in the PHQ-9. And it's showing you the different 3 countries, so it's Kenya, Uganda, and Ethiopia, and then the different settings. So as we mentioned, we have samples in both living in camps, but also in urban settings. The light blue is refugees, and the dark blue is host population. So, the main message of this graph really is to show the very striking differences there are between the refugee populations and the host population in terms of prevalence of depression, where on average, we find that 31% of refugees were above the cutoff of 10 or above versus the host population, which was at 10%. And then we also looked at different associations with other sociodemographic characteristics. And so we find that being female, older, and longer duration of exiles was correlated with higher prevalence of depression. This is for prevalence of depression. And then I show you the other measure which we use to assess mental health, which is functional impairment. Here, the higher the score, the higher the impairment. And again, we find very significant differences between the refugees and the host population, where we find that refugees scored significantly higher on the functional impairment score. They actually 62% reported severe impairments compared to 25% of the host population. So there were a lot of, when looking at what does it actually mean to be functionally impaired or to have severe functional impairment. So when we look at specific items of this HUDAs, we see that around a third of refugees reported severe impairment when it came to walking, to doing household chores. There's also a quarter of them that said that they found it very hard to stand, to concentrate, and to join community activities. So only these two graphs show you that the knock-on effects that depression has on many other spheres and domains of their life is significant. And so that's where we're presenting the difference between the host and the refugees. The other thing that we want to point out, I guess also parting from what Raphael was saying around how much heterogeneity there is within refugee groups. And so this graph has a lot of information, so I wanted to split it up into different steps because it's a little bit hard to follow, so just bear with me. So this is again showing you the high depressive symptoms, so again showing those that are in the cutoff of 10 or above, so moderate to severe. And again, I'm showing you the three countries, so Kenya, Uganda, and Ethiopia, and the different settings, either in the camp or urban settings. And then the different colors that you're going to see depends on the different refugees groups that we have data from. So just showing you the first set of refugee groups. So that's those living in Kenya in the camp. We have DRC here in light blue, Somalia in green, and then South Sudan in gray. And you have also the 95% confidence interval. So here you see there's some differences between refugee groups, but actually there's not statistically significant. So overall, you have around 30% or so that are moderate to severely depressed, with no significant differences between refugee groups. When you go and see what is the difference between the refugee subgroups in urban settings, so that's DRC and Somalia, you see big difference between prevalences. Similarly, when you go to Uganda, you also see very big differences between those that are living in a camp, so those from DRC, versus those from Somalis refugees living in the camp settings. Again, big differences when looking at cities, so Kampala, compared between these two refugee groups. Moving into Ethiopia, we see that 20% of refugees from Somalia were above the cutoff. And when you look at the same group, but in urban settings, you see that the prevalence of depression was much higher and significantly so. So that's just that really like some descriptives and it just gives a little bit of a taste of the kind of data that we have. And this is a correlational study, so this is a descriptive study. That's as much as we can say with the design that we have. But I think it really raises the question of what is happening with some of these refugees. Why are there so many differences across them? And are there any interventions that can be done to target more those that are most at risk in some of these settings?
Thank you, Julia. In similar ways, this graph that you're seeing right now shows the violent event number per 1,000 inhabitants in the country of origin. So the graph is split up in the same way that the three countries, Kenya, Uganda, Ethiopia, where the refugees live, so in the camp, in the urban context, and then comparing by the color where people come from. And what is striking here is that we see a very high number, relatively speaking, higher number, that Somali refugees have faced basically the highest violence across the context, at least measured by ACLED data, and that urban refugees in Uganda and Ethiopia experienced more violence than those in camps. There is a difference between Somali refugees in the camp context in Ethiopia and the urban context. And I don't want to speculate too much about why that might be the case, but it could be driven by people coming from different contexts and fleeing at different points in time. And so a lot of refugees that are living in the Dolo-Ado camps in Ethiopia might have fled from drought, for example, rather than being exposed to violent events that were picked up. So the prevalence of of violence exposure through the self-reported measurement is strikingly high. So 72% report that they have been exposed to violence or torture, 62 as direct victims, and 64 have witnessed that. So there's a significant difference that we see between these different contexts. And mainly, it seems that like Congolese refugees report high levels of violence that was not picked up, measured through the ACLED index. And we've also seen in the data that being older is associated with a higher degree of self-reported exposure to violence. And we found no significant association between sex and self-reported exposure to violence. Yeah, do we want to look at talk about the differences and the connection?
Yeah, so now so that was descriptive. So it's prevalence of depression, prevalence of exposure to violence with the two measures that we have. Now we're going to go and look at correlation between, so that was objective number 1. Now moving on to objective number 2, which is how does exposure to violence pre-exile is correlated with mental health outcomes. And again, I'm splitting the graph in different parts just to make sure that it's understandable. So instead of showing just regression tables and a lot of numbers, we are visualizing the regression results. And so what you're going to see here is, so this is the standardized coefficients, so the effect sizes in standard deviations, and then the 3 outcomes that we're focused on in mental health. So that's depressive symptoms, just the continuous score. This is high depressive symptoms, so those that are above the 10 cutoff, and then the functional impairment score. Again, the higher the score, the higher the impairment. Anything, so I'm going to be showing the effect size, the average effect size, but also with 95% confidence interval. So anything that touches the 0 basically is not statistically significant from 0. So when we first look at depressive symptoms, this is showing the violence exposure with the ACLED measure, so this objective measure that Raphael was discussing. And so what we see is that the higher the violence exposure, the higher the depressive symptoms, and that is statistically significant. Looking at the high depressive symptoms, so the binary variable, we again see that there is a positive correlation between exposure to violence and having depression, so moderate to severe depression, and the same thing for functional impairment. When we look at the violence exposure with the self-report measure, we see very similar results, but actually bigger effect sizes. So you'll see that this is above 1 versus this is effect sizes around 0.5, 0.4. In general, just to give a sense of like how big these results are, even though the effect sizes are small, it does mean that experiencing violence increased the likelihood of depression by 17 percentage points and functional impairment by 18 percentage points. So overall, a positive correlation and one that accumulates over time. Another thing that we're not showing here, but we did find is a dose effect relationship. So the higher the exposure to violence, the higher the effect size on depression. That's on violence and mental health. Now, moving on to the effect of violence on socioeconomic outcomes. Again, I'm going to be showing the same graph, but with now all of the socioeconomic outcomes. So these are the ones that Raphael presented and described. So this is having an income generating activity, so employment status. Then for those that do have employment status, what is the monthly income? This is monthly income for everyone. Then the life satisfaction, and then the dietary diversity. Again, we have on the left-hand side, the exposure to violence with the ACLED objective data, and then we have on the right-hand side, the violence exposure with the subjective self-report data. And here, basically, what you see is that many of the socioeconomic outcomes are actually touching the 0 line, so they're not statistically significant. But we do see a difference in positive, significant correlation between violence and the socioeconomic outcomes when we look at the violence exposure self-reported. So we see that in general, those that were exposed to violence had actually a higher chance of having employment, but at a lower income. And then they had lower life satisfaction and lower dietary diversity. So what time is it? So we have 10 minutes. So maybe maybe we continue. One thing that it was striking for us to see is this effect of actually we do see that people are more likely to have a job, but at a lower pay. So that's something that we explored a little bit more, and we found that actually on average it actually means that they are basically compromising, so they're getting whatever job they can at a lower pay because they prefer that to basically going back to their countries, which was another follow-up question that we asked. But we can maybe move on and then discuss that in the Q&A. And finally, the last set of results that we're going to show you is the link between depression and the socioeconomic outcomes. And basically what we see, again, as we started the discussion, is that depression is not only an illness that has clinical effects, but it has knock-on effects on very different dimensions of your life. So those that had higher levels of depression were also, those that were exposed to violence had significant economic challenges. So they were less likely to have a job. They were less likely to have a job. They had lower income, lower self-satisfaction, and lower dietary diversity. Okay. Yeah.
Maybe to bring us, wrap this up and then bring us to an interesting conversation is to just highlight quickly what obviously the study limitations are. So besides from a lot of challenges in the context, I think it became pretty clear that this is an observational design, right? So we're not trying to say that these are really causal effects. We've been very cautious about making the best interpretations here, but obviously this is only observational, and it's been it's very difficult to really determine the relationship between mental health and the socioeconomic outcomes, and also what happened before exile and during the exile. And it's obviously very difficult to dissect these different temporal effects. And we used validated screening tools, and therefore this is really much just describing the symptoms that we measure, but it's not a clinical diagnosis. And I think this is very important to point out, that we can't say somebody's depressed or not depressed. We're not trying to. And there are many other factors that influence how people are, how people's mental health is, but also that influence why people are fleeing. And we've looked very particular on contexts where most people were affected by conflict-related displacement, but in other displacement-related, other displacement communities or contexts, that image might be different, right? And so you have to be aware of what is driving this particular people in this particular context and what has influenced them. Let's summarize our key contributions. We focused on a very understudied refugee population in Eastern Africa, and therefore I think our key contribution is that we add something to the literature where basically there was a huge gap. We examined both urban and camp contexts, and can therefore say something a little bit about the population as a whole, rather than about just this particular context. We have a very large sample size and can therefore generalize quite comfortably. And we employed a very comprehensive survey and a list of very different ways of measuring effects. As we said before, our main findings is that we have very high rates of depression among the refugee population. An average 31% of all, and let me correct myself here, depressive symptoms, not depression. And so very high number of depressive symptoms among refugees. On average, 31% have suffer from moderate to severe depressive symptoms. We have 62% of the population suffering from functional impairment, and this is significantly higher than the host population. We have a very high exposure to violence, and we can see that there seems to be a link between the exposure of violence, the mental health situation of refugees, and how it affects the socioeconomic outcomes. And we could show that there seems to be a link between the depression, the depressive symptoms, and unemployment and lower wages, as well as life satisfaction and the dietary diversity. Maybe to wrap this up, so the clinical implications here I feel are pretty straightforward. We think that the longer duration of exile and the effect of the mental of the violence before should be taken into considerations, and it has to be important. Like it's important to address that in the post migration conditions. So refugee camps, refugee settings, refugee host settings should focus on that. We think that there is a need for early screening and more evidence-based interventions. And we think that treating mental illnesses may improve the socioeconomic outcomes. And linking these two debates, I think, is really important. I'm saying this as somebody who comes predominantly from the economic or refugee economies program, that we often talk about what is necessary to have the economic integration and help the economic integration of refugees in host countries. And really understanding that mental health effects hinder or might improve that economic integration is really important to move forward. Thank you very much, and we're open for questions and looking very much forward to discussing these results with you. Thank you.